Nick Majerison here. Welcome to Top Med Talk. Make sure you listen to the end of this podcast where we have a special announcement about how you can have the entire Top Med Talk back catalogue for free. Before that though, today's Top Med Talk is ASA 2018 San Francisco, the Smith's Medical Symposium on Enhanced Recovery. Recorded before a live audience, this Q&A session was at the meeting of the American Society of Anesthesiologists, the ASA, at a specially hosted dinner where those in attendance and the online audience could submit questions. This is part 2 of 6. And this piece features Desiree Chappell interviewing her guest Vincent Chan, Professor of Anaesthesia at the University of Toronto, with contributions from Monty Mython, Top Med Talk Editor-in-Chief and Smith's Medical Professor of Anaesthesia and Critical Care at the University College London. Have a listen.
Top Med Talk.
Dr. Chan is going to be our next guest, and he is going to be talking to us about regional anesthesia. So, Dr. Chan? Yes. So, Dr. Vincent Chan, please give him a round of applause. Dr. Chan, thank you so much for joining us.
Thank you for having me.
Yeah. So, Dr. Vincent Chan is a professor of anesthesia from the University of Toronto, and he is an international leader in regional anesthesia. Now, you've received awards and distinctions for from regional and pain medicine organizations from across the world, actually. So a true expertise in this area. So thank you for joining us. And we are going to go ahead and ask questions in just a moment. But I'd like you to give a little bit more about your background in regional and pain medicine at the University of Toronto.
So I've been around for quite a long time. I am passionate. I like regional anesthesia. I started out, in fact, in chronic pain. I did a fellowship in chronic pain and then changed my focus and go into acute pain and then finally in regional anesthesia. And my original journey is to make regional anesthesia more consistent, and that's why I got into ultrasound-guided regional anesthesia and continue to learn. So the next phase to us is, again, point-of-care ultrasound. All that is trying to improve patient outcome, and I think all of those techniques will help with the enhanced recovery program. So that's my
that's your
journey.
background. Great. Well, good. We have Slido up here. So some of the things we talked about before we got started here was really kind of diving into regional anesthesia and utilizing it in practice and the difference that it makes for our patients and why we're using that. So can you talk to that just a little bit more?
So for me, regional anesthesia is a procedure. So always there is an extra procedure that we do. I feel that whenever you do an extra procedure, I always ask the risk versus the benefit. So I don't take it lightly. I would ask myself, are the benefits outweigh the risk? So for something that is very painful, severe pain, then clearly regional anesthesia is a good option. It's always a good, as a multimodal analgesic technique, it's opioid sparing. So I think your surgeons will be very receptive, patients will be very receptive. Also, I ask myself, what other benefits do I expect from regional anesthesia? Is it only for patient comfort, or are there other things that I want? So for severe pain, I think that's a very good example. Patients cannot breathe well, cannot cough well after a major thoracic and abdominal procedure, so that is a clear advantage. But then when you go to minimally invasive procedures, keyhole surgery, mild pain or slightly moderate pain, then I ask myself, is it really indicated? If I have other multimodal analgesic techniques, is regional anesthesia truly indicated? I think many of us are doing it, but I don't think the evidence is very clear at this time. More studies need to be done because many of the new blocks that we do are all comparison with placebo, not a good outcome comparison with different analgesic drugs. So I think we need to be more critical about what we do. Any blocks we do have some risk. And then I always ask myself, is it the right thing to do?
Good thing to do. One of the other benefits that we had talked about before was the opioid sparing and reduction in opioids that we use for our surgical patients. So what have you seen in your personal practice about using that to address the reduction of opioids?
So this is another big question we are asking. Historically, when we look at regional anesthesia studies, we always look at pain relief. Is it a reduction of the VAS score, pain score, by how much? Reduction in opioid consumption, by how much? And most of the studies will show that is statistically significant, no question. But I think the important question to us is, does it reduce opioid-related side effects? Does it improve functional outcome? And I think we need to set a higher bar. Reduction of 10 to 20 milligram of morphine a day is statistically significant. But does it make any difference? It's not the price. The price is very cheap. So yes, I take another more opioid. But what is the outcome measure? So again, from enhanced recovery, I ask the same question. Does drop in a little bit of pain score and opioid consumption really help with enhanced recovery? I think, again, regional anesthesia is just one component. We have to look at all the other components and add together and see whether we can get our patients' outcome better and decrease the length of stay.
Yeah. So let's go ahead and jump right into some of the questions here. The first one we have here, does the short-term use of opioids in major surgery really contribute to the opioid crisis?
I mean, that's the big question, right? Does it? I think many patients' first exposure to opioid is after surgery. Right? So then it's really up to all of us care providers in how we deal with the opioid prescription. We know that many times opioids are prescribed too easily and the quantity is way too much. So I think now the pushback is, yes, we have to be very careful about how much. But I don't think short-term use of opioid is a bad thing. We have to use our common sense, appropriate judgment. And for those patients who have difficulty coming off, we do now provide the transition pain clinic. We follow them and we help them to reduce. So the important thing is we know how to go up with the dose, but we also need to come down with the dose and wean them off.
Yeah.
If I could, because there's quite a lot of pressure at the moment to go opioid-free. And that's a big paradigm shift.
Yes. I don't believe. I think opioid sparing is important.
Yeah.
I don't feel that opioid is such a bad thing, given that we must use it with care, with common sense. We know how much and how long to use it. So no drug is all side effect free.
100 of fentanyl, 10, 20 of morphine for a big case, which wouldn't be that unusual. Isn't the real issue the sort of OxyContin that people are sent home with, or the unnecessary use of opioids? I do think we need to strike a balance before we go opioid-free completely.
I agree.
I may turn out to be completely wrong, but that's quite a difficult shift. Just pulling back a lot is probably step one.
It seems like there was a reactionary kind of thing here in the U.S. where it's like all or nothing now.
Well, I'd like to hear the audience how they feel. But yes, I think the pendulum has swung too far to the other side. I still remember in the early 90s, we have this button, no pain. And at that time, my surgeons already tell me, why are you promoting this? It's acceptable pain, tolerable pain, not zero pain. So now we go to the other side. It's zero opioid. I'm not so sure that's the right thing.
Definitely an educational component there.
Yeah.
So, all right. What kind of benefit should we expect beyond pain control, and what kind of benefit to expect beyond pain control and opioid sparing? What other benefits of using regional anesthesia do you see?
Well, again, I look at functional outcome. It's very easy to show the benefits of regional anesthesia in something like big operations, right? Major abdominal, thoracic. Patients cannot breathe, cannot cough. Of course, you want to control pain so that they relieve the splinting, so that they don't get into pulmonary complications. And then for total knee replacement is still an open procedure, it's painful. So all regional anesthesia is a clear role. We can control pain without impairing the function, without impairing the movement of the leg, the muscle weakness, and that's a good thing because my focus is not just pain relief, but was also functional recovery. How do we improve that?
Because I think we also completely agree with all that, but we also have to be careful that the use of regional techniques doesn't result in immobilization and leaving urinary catheters in. So you've still got to strive for all of those enhanced recovery targets, and it should enable that, not inhibit that.
Absolutely.
All right.
Top Med Talk.
I mentioned at the start our back catalogue of over 300 podcasts. You can download all of these completely free today. Top Med Talk is committed to open source publishing and will remain so for all new material. As we continue to grow beyond our expectations in subscribers and engagement of thought leaders around the world, we will be diligently working to enhance the experience of our listeners by creating a back catalogue, a highly curated collection of our podcasts, advanced search options and special bonus features. This will be available through our new app at a fee. So we encourage you to download all of the podcasts right now. It's completely free through to the end of this month and contains some absolute classics from some of the greats. Enjoy.